Yeah, pretty much got everybody in now. Okay, so welcome everyone. This is our second webinar of Bone Cancer Awareness Week 2020. In a moment, I'm going to hand over to my colleague Zoe, who's that way, who's going to officially introduce tonight's session. Just a few housekeeping things, just so you're aware. We will take questions towards the end of the webinar, and if you could just use the comments feature in order to submit those. We should have about 10 to 15 minutes, so we'll try and answer as many as possible, but if we don't get to your question, please do feel free to email us back to the email address that you got the invite for tonight's webinar on, so info@bcrt.org.uk. Send your questions to us and we will get back to you on those as soon as possible. Tonight's session is being recorded and we will upload it and make a link available so that you can watch it back, or you can share it with your friends, your colleagues, your peers, etc. after tonight's event. You are on mute, as I said, please just stay on mute. You can turn on your video if you like. It will be recorded, so just be aware of that, or you can remain with the video off. And that's it from me. I'll come back to you when it's the Q&A at the end. Over to you, Zoe.
Hi everyone, welcome to our webinar. We're quite overwhelmed by the response, so I hope you enjoy it and find it useful. So I'm just going to share my screen now. There we go. So I'm sure many of you don't really know who the Bone Cancer Research Trust is, so I'm going to give you a bit of an introduction to who we are and a bit of an overview of the webinar. So in 2004, a group of parents that had lost children and young people to primary bone cancer were all fundraising independently, and they were brought together by a clinician, Professor Ian Lewis in Leeds. He had seen all of their independent efforts and actually felt that they could make a real difference if they were joined up and fundraised together. They were all quite fed up and frustrated with the lack of research that was going on into primary bone cancer. None of the families felt supported, there was no one there for them, and there was a lack of information on each type of primary bone cancer. And they really did want to change that for the families that came next. So in 2006, the Bone Cancer Research Trust was registered. So today we are the leading charity dedicated to primary bone cancer, and we offer hope to all patients. And our vision is for a world where primary bone cancer is cured for all patients. And our mission is to save lives and improve outcomes for patients through our 4 pillars of research, information, support, and awareness. We're a small team, there's 16 of us at the minute, but we are extremely dedicated and passionate to making a difference to our patients. And unlike other charities, we are not based in London, we are based in the sunny north in Leeds. So in 2017, we launched a new 5-year strategy, the 2017 to 2022 biggest commitment to primary bone cancer ever strategy. So this covered our main aims and objectives across our 4 pillars of work. And I'm just going to highlight what we said we would do in our awareness pillar. So we said that we would save more lives and increase survival rates through raising awareness of primary bone cancer amongst the public, healthcare professionals, researchers, and policymakers. So we've already made a start on our awareness work. We did have an e-module for GPs, which has been archived at the minute, and that's under review. We actually want to kind of review the way that we engage with GPs. We support an e-module for medical students, which we work with a clinician in Liverpool, Mr. Chandrasekhar, and he runs that. He does a SurveyMonkey questionnaire, and the top students we support to do a fellowship at a sarcoma centre. And with the help of our GP ambassador, we released a symptoms video, which is on our website. You can view that. And Last year, as part of Bone Cancer Awareness Week, which is this year, we managed to reach over 4 million people worldwide, and we're hoping with your help that we can reach more this year and can top that figure. So I just want to touch on why we're really here, and that's because we want to make things better for our patients. So this is Harmony. Harmony was 8 years old and she developed this lump in her arm. You can see it here. She went to a GP who thought it was an infection, prescribed antibiotics. She went for a second opinion at A&E, the same, and then went to see a specialist paediatric consultant, and again was told that it was an infection, even though there was no infection markers in her blood work. It was only when a family friend who was a paramedic said, actually, that does not look right. I don't think that's an infection. I think we need to get an x-ray. He actually booked an x-ray for Harmony, and that's when it was discovered that there's something really sinister. The x-ray showed that something had started eating away at Harmony's bone, and a few weeks later she was diagnosed with Ewing sarcoma. And this is Claire. So Claire was experiencing pain. She went to her GP. Her GP referred her to a physiotherapist, and actually it was the physio that recognised something that wasn't right. She sent her back to the GP with an urgent message to refer for imaging, and then Claire was diagnosed with Ewing sarcoma. Claire's doing well now, thankfully. She is okay, and she has a little family. There's a whole host of patients that we want to speak about and for, and you can see a number of their stories and their experiences on our website. So please do go to our website and have a look at them. They've all got an incredible story of bravery. So why do we want to educate healthcare professionals? This all started really in 2015. We undertook a piece of stakeholder research, and a report was drafted from that called Living with and Beyond Primary Bone Cancer. And it documented a patient's journey from their diagnosis through their treatment and life after a primary bone cancer. And it really did give us our first glimpse and our first documented evidence of huge problems with diagnostic pathways. And as part of this, we interviewed patients, and this quote is quite haunting. So it was, when I was finally diagnosed, I didn't know if I could go through the treatment. We had fought so long, I didn't know if I had any fight left in me. And the most heartbreaking thing is that this is from a 14-year-old child. And we feel, and I hope you agree, that no one should be left so exhausted from battling to get a diagnosis that they can't face their treatment. So in 2019, we hosted 5 medical students from the University of Sheffield, and they looked at our education portfolio and reviewed this, and they decided they wanted to make something specifically for medical students. So they developed this flashcard. So it's the size of a postcard. It's matte. It allows medical students to write on it and make notes. And it acts as a kind of revision card covering all the main points of primary bone cancer from risk factors through the diagnostic tests that need to be done and investigations, right the way through to the epidemiology. And actually, since they've been made, we've found out that they're actually useful for a number of healthcare professionals. They've been used by GPs as part of reflective learning, and they've been used amongst physiotherapists. And this is really what kickstarted this project and this awareness campaign. At the same time, we have developed a really strong relationship with another charity called Children with Cancer UK. This was developed at the end of 2018 and going into 2019 when we were working on an osteosarcoma symposium. And actually both charities have got an aligning priority on early diagnosis. So together we have launched the Bone Cancer Awareness Initiative. which is a 100-day project, which started in July and is culminating this week as part of Bone Cancer Awareness Week. So it's the Bone Cancer Awareness Initiative, Saving Lives Through Earlier Diagnosis. And as part of this, the Bone Cancer Research Trust did a large patient survey. We actually need to know how bad the problem is if we want to try and fix it. So the survey was done through SurveyMonkey, promoted by our social media and our support and information service. And it had two main focuses: the time and route to diagnosis and the breadth of symptoms that patients experience. And we have an inkling that these might be different depending on where the tumour is. Tumours can affect any bone in the body. So we had a really impressive response to the survey. We had 739 responses. We had 312 from the UK and 426 from outside the UK. We don't know exactly where those 426 were, but somewhere outside the UK. And one person, if you're counting and doing the maths, one person didn't actually tell us where they were. So we then analysed the results. And I'm just going to talk through some of the key findings. So the survey was answered by patients themselves, both current and former, by parents of patients, or by a friend or other family member. As I mentioned, they resided both inside and outside the UK, and we had a fairly even split between males and females, although it's the flip of the normal incidence. Normally, more males than females are affected by primary bone cancer. So the age at diagnosis reflects what we normally see. So we have a peak in children and young adults, and we still have some in later life. And actually, the year of diagnosis, we saw most actually fairly recently, which means that our results are current and usable. In terms of reporting symptoms, overwhelmingly patients went to their GP first, with just a small amount going to A&E and other healthcare professionals. And the outcome of this visit, 21% were asked to return if symptoms persisted, but we actually want to know whether they have adequate safety netting in place. Is it prescriptive follow-up, or were they just relying on patients coming back? And actually 28% were dismissed or ignored, really, with no intent of follow-up. And these patients were referred onwards. In terms of number of visits, it's quite shocking, really. 8 visits to any healthcare professional for patients in the UK, slightly less outside the UK, statistically significant, and over 4 visits to a GP before a referral was made. And just to emphasise, patients are getting bounced around between healthcare professionals. So 58% visited 3 or more different professionals before they were referred. In terms of time to diagnosis, the average time to diagnosis in the UK was over 7 months. 25% had to wait more than 7 months, and 13% had to wait more than a year before they were referred. And unsurprisingly, there was a lot of patients that were diagnosed with something else, a misdiagnosis. Up to 6 misdiagnoses were received. Growing pains was overwhelmingly the biggest one seen, particularly in children. 43% of our children were dismissed with growing pains, which is quite worrying. In terms of who made the referral, these came from a variety of sources, which just really emphasises how many healthcare professionals we need to make aware of the signs and symptoms, because patients go everywhere. So on that note, I'm going to hand over to Krista.
Hi everybody, just bear with me 1 minute. I'm just going to share my screen and load up a PowerPoint. That's okay. Okay, perfect. I'm hoping that you can all see my PowerPoint now. And it should say recognizing sarcomas. So hi, good evening everybody. My name is Krista Bose. I'm a final year medical student at St. George's Medical School in Tooting. And today, or this evening actually, I'm going to be talking to you about recognizing sarcomas and primary bone cancers. I will try my very best to make it interesting and informative because I know it's like a dreary, rainy Tuesday night, and hopefully we will all get through this having learned something. Okay, so why am I giving this talk? As I said, I'm a medical student. I'm in my final year, and some of you may have met me before. I don't know if anybody there is from St. George's. If so, hi. But some of you may also, if you're interested in medical Instagrams, you might have seen my blog. It's called Squashing My Sarcoma. So if that blog title didn't give it away, I should tell you that I'm not only a medical student, I'm also a cancer patient. I was diagnosed with one type of sarcoma about halfway through medical school. And looking at this picture of me, which was taken a few weeks ago when I started my A&E placement, I bet you wouldn't be able to guess where my sarcoma was. I mean, it is difficult to tell while you're wearing scrubs, but anyway. I had to take 1 year out of school for treatment and for surgery, and I'll talk more about that later, but I'm very lucky to have been back at school for over a year now. I hope that tonight, by sharing some of my personal experiences with bone cancer, you'll remember some of the common signs and symptoms, and hopefully a bit of my story will come into your mind when you next meet a patient, whether you're graduated and you're in your own practice or even as a student, and hopefully that sarcomas and primary bone cancers will just appear at least once on the list of differentials that you'll always have in the back of your mind. I also want you to consider looking for them on scans and on films because they're often missed there. And if you're just keeping an eye out for them, it would be great. Because after all, if you could recognize a sarcoma earlier, you could save somebody their arm or their leg or even their life. Right. I hope these are all going forward. I'm assuming they are. Why should we be learning about primary bone cancers? Well, we know that they're rare. They're only about 1% of all new yearly cancer cases in the UK, which sounds really rare. And when you compare it to all the other cancers that are more common, you think, why do we need to know about this? There's a statistic, or a saying, I guess, that often gets bandied around when people are talking about bone cancer. It goes, a GP working in the UK is unlucky if they end up getting a single patient presenting with bone cancer. Just think about that statement for a moment. Most GPs don't even see one case in their working lifetime. And more importantly, they say the GPs are the unlucky ones. Let's be honest, this catchy statistic was probably written by a doctor and not by a patient, because if it was written by a patient, it would say we are the unlucky ones. We are the very unlucky few to be affected by sarcomas. Why does nobody seem to know about this? Why are we never featured or campaigned for? Where are all the yellow ribbons? And you might think that doctors and health carers are not aware of this because it's uncommon, but actually as medical students, we often learn about uncommon things if they are, as most sarcomas are, likely to kill people. So although this might seem like a semi-dramatic introduction, the first point that I'd like to make tonight is that in this group, we have a responsibility to remember the word sarcoma and to learn about primary bone cancers and to raise awareness to help those unluckiest of us get diagnosed sooner, much sooner, because it's taking far too long as it is for people with sarcomas to be referred on to the specialist centers from their GPs. In some cases, it's taking years. And that is not good enough for me. The overall prognosis for people diagnosed with sarcoma is less than ideal. If you look at my slide, it says 55% of those people diagnosed with sarcoma will be alive in 10 years. So that means 45% of those people will have died. And if you can imagine that a lot of these people are being diagnosed quite young, a 15-year-old might have less than 10 years left to live, and it's shocking to me. It's really quite sad. Right. So now that I've told you how horrible it is, I want you to think about all the things that you've learned so far in your medical studies about sarcomas. Have you had any lectures, webinars during COVID, even maybe any PowerPoints, and just grasp in your mind all of the key facts that you can remember? How well do you think you could tell apart the different primary bone cancers? I think that before I was diagnosed with a sarcoma, I had very, very little knowledge about sarcomas myself, and I wouldn't be surprised if most people listening to this PowerPoint or to this presentation had barely ever heard of primary bone cancers before or knew very little about them. And yet, we all know the red flag symptoms of cancer. So I hope if you're a medical student and you're in your first year, second year, you'll have learned some of these red flag symptoms. They're very commonly brought up in practice and in study. We're thinking about things like weight loss, fatigue, bruising, night sweats, and fevers. Now, this could definitely happen for a cancer patient and a bone cancer patient. But what I want you to think about now is if you can think of any symptoms of a bone cancer patient. And it can be difficult because a lot of the symptoms that people get with bone cancer can be different from other types of bone cancer, and there's a myriad of symptoms. So look at these two columns and tell me which column is the symptoms of sarcomas. We've got constant pain, pain worsening at night, pain tender to touch, pathological fractures where someone's presenting in with a fracture with no known injury or cause, any visible atypical swelling that's not in the joint or resistant to analgesia. That is true. They're all true. But what about the other side? Intermittent pain, daytime pain, loss of muscle tone, limping, no visible swellings or joint stiffness, and the neurological symptoms as well, especially these. These are all also true. So I could completely understand how you could meet somebody with some of these symptoms and then get confused because some of them seem to contradict each other. And that just goes to show the vast variety of the symptoms that could present with somebody with a bone cancer. Right. Now, I'm going to briefly go through the 9 types of sarcomas that are represented on the Bone Cancer Research Trust website. This is because I want you to be familiar with the different types. I completely appreciate that some of these are quite rare, but I still think it's really useful to know and to learn about. And I hope that these slides will build on the medical learning that you've already had. All of the information and the statistics, as I said, was taken from the BCRT website. And just so you guys know, it's the same information that you would get if you were a patient recently diagnosed. So it's nice to kind of put yourself in the shoes of a patient and imagine that you've just found out you've had a sarcoma. This is the kind of information that you're going to get. And for anybody that wasn't aware, a sarcoma just means any cancer of the connective tissue. So that could be hard tissue, bone, or it could be soft tissue. Right, so let's go through. I've blocked out the names of them. So if you're feeling like you've revised this before, maybe you could try and guess. But the first one is the most common type of primary bone cancer. It's often found in young people, so age 10 to 24, and it's common in tall, young male patients. Also, really interestingly, it can be found a lot in tall dogs, like Great Danes. It can be common with certain risk factors, like Paget's disease of the bone, retinoblastoma, which is an eye cancer, and previous radiotherapy or other genetic factors. Right, so this is osteosarcoma. This is the most common type of primary bone cancer. 160 people are diagnosed in the UK every single year, and the survival rate for 5 years is only 55%. So if you imagine that you're a 10-year-old child and you've just been diagnosed and you've been told it's like flip a coin, it's just shocking to think that, you know, there's not more being done to support people with this type of cancer. These types of cancers are normally treated with surgery, chemotherapy, and sometimes also with immunotherapy. They're most often found in long bones, like the femur, most often. Right, second most common in young adults. So it's not the second most common overall, it's the second most common in young adults. It's also seen in tall, young Caucasian male patients, and it's thought to be related to growth spurts. 85% of these present in bones, hard tissue, and only 15% in soft tissue. Another really shocking statistic that I wanted to tell you all about this type of Ewing sarcoma is that at diagnosis, 25 to 30% of patients have METs. So if you imagine being told you have cancer, the only thing worse, and I'm telling you from experience, is finding out that you not only have cancer, but you also have metastases. 100 people are diagnosed in the UK every year. And the 5-year survival rate for Ewing's is about 60%. Another really shocking statistic about Ewing's is that 10% of patients require an amputation, which is quite high. If you think about 1 in 10 of these children are going to need to have a limb amputated. That's quite a lot. Right. Next one. This is the most common primary bone cancer in adults. And if you can guess, it's made of the cells that normally form chondrocytes. So it's a chondrosarcoma. Interesting thing about these cancers is that 20 to 30% are symptomless, and they may only present with a pathological fracture. So if someone comes in to A&E or to somewhere where you're working and they have a pathological fracture with no symptoms, you should still consider this. This accounts for 25% of all the cases of primary bone cancer, and it once again is treated with surgery, and because they're usually slow growing and non-metastatic, they don't always need radiotherapy or chemotherapy, but you have to keep it in mind. Right, next one. These are getting now into the more rare types of primary bone cancer. So the 3 most common we've already covered, and if you can remember those 3, that's brilliant. This one is usually occurring in the skull or spine, and it's derived from the notochord. If you remember any of your embryology lectures, you'll remember that the notochord is like the pre-form of the spine, the spinal cord. And so if you have a cancer called a chordoma, it presents in the spine. 50% of them present in the base of the spine at the very bottom, and they may present with neurological symptoms. So when you see a patient coming in who's lost control of bladder or bowel, or who has any numbness, tingling, other sorts of neurological symptoms, keep this up on the top of your list of diagnoses, of differentials. It's really important not to leave these things out, because if they're missed, it can be catastrophic. Right, only a few more. Sorry, I hope I'm not overwhelming you with information. Right, next one, we're a bit more rare. These are called spindle cell sarcomas, and there's 3 different types: leiomyosarcoma, a fibrosarcoma, and a pleomorphic undifferentiated sarcoma. Basically, these are treated a lot like osteosarcomas in terms of treatment, and they're often found in the long bones. These guys are more common in ages 40 plus, so not so much in young people. Next, we have these adamantinomas. Now, these are also really interesting because they really commonly occur in the tibia bone. And what's interesting is that they're also usually associated with a history of injury or trauma. The way I remember these is that when patients, I mean, I can personally imagine hitting my shin bone quite frequently, on legs of tables or chairs, or sporting injuries. It's easy to imagine how you could have an injury or trauma to this bone, and it's associated with this type of cancer. Okay. It has to be also treated with wide surgical margins, because although it's slow growing and low grade, these cancers have a very high rate of metastases many years after completing treatment. So even after completing your treatment, maybe many years later, they could have a recurrence, which is obviously a devastating thing. Right. Angiosarcoma of the bone. These tumors are quite aggressive, because if you think of and the derivative of the word angio is a blood vessel. So like angio is, the Latin for the lining of the blood vessels, which is the endothelial cells. And if you have a cancer in a blood vessel, it's already at the perfect place to spread, because it can spread through the blood. So angiosarcomas are also very aggressive with very high rates of recurrence. And they're tumors that arise from the cells, like I said, which line the blood vessels. You can have angiosarcomas in different organs. So the blood vessels could be penetrating any organ, the liver, the heart, anywhere. But angiosarcomas of the bone make up 6% of all angiosarcoma cases. Okay, I'm almost done with all of these. Next one is primarily benign. So this one is not as sad, but they can recur as a malignant tumor. So once again, they need to have surgery to make sure that they're completely removed. If you think of giant cell tumors of the bone, you can think of them around the knee joint. and they're more likely to be diagnosed in people between the ages of 20 and 45. Okay, this is the last one. This is called an ameloblastoma. This is a benign tumor that forms around the mandible or the maxilla. Okay, it's a benign tumor that forms in the jaw with a very, very high risk of recurrence. And although it's benign, it does have a very, very high rate of causing local invasion, just because it's difficult to surgically remove and it can be locally aggressive, can cause problems with wisdom teeth and things like that. Right. That was my one-stop shop like coverage of all the top 9 types of primary bone cancer. But now we're going to talk a little bit about how this is significant to me. And yeah, I'm going to see if you guys can figure out what kind of sarcoma I had with all of those little helpful slides. So you are now an F1. You're working in your GP practice. It's your first day, and your patient comes in and she's complaining of leg pain. She's got fatigue, night sweats, malaise, and weight loss. She's young. She's only 24 years old, and she shows you this lump in her left leg. I hope you guys can ascertain where the lump is. It's got a bit of shadowing around it, and you should be able to notice it. Are you worried? Are you concerned? Are you willing to refer her or think about doing anything else at this point? What would you do now? As soon as you see her, you're in the GP practice, what would you want to do? So I hope, like any good medical student, you'll have said in your head, oh, we'll do a full history and an examination, of course. So make sure in your history you ask about risk factors for sarcomas. My slides are quite dense, but they are there on the slides. A lot of them have genetic risk factors. Another big factor that increases risk is exposure to previous radiation. So if you've had a previous cancer that was treated with radiation, it's not uncommon to then have a bone cancer afterwards. Also look for things like sporting injuries, any injuries to the bone, or any other red flags. But obviously in this little short brief history, you can see that the patient is having some red flag symptoms of cancer. Right. What I would recommend doing now, before we do anything else, which someone did for me once, is to measure it. It's a really simple thing. If someone presents in and you're not sure what their swelling is or their lump, measure it. You can also examine the lump. You could draw a circle around it with a pen or a marker to see if it's grown. And you can also check it to see if it feels warm or it looks inflamed. As you can hopefully see from the picture, this one doesn't look particularly inflamed. It's not red or hot to touch. And you could ask the patient if they'd be willing for you to take a picture for your own reference to check it again if they were to come back. As was previously mentioned, patients see their GP up to 8 times before getting a secondary referral. So if you're seeing your patient return 8 times to you, you would want to have a picture and a measurement to compare to your previous time. Right, so we're now concerned. We're not sure what this is. It looks a bit daunting, and we've noted all these red flag symptoms in the history. I hope you would now, if you didn't know what to do, you would now consult the NICE guidelines. So the NICE guidelines actually say that if any primary healthcare professional does have current concerns about interpreting a patient's signs or symptoms, then right away you should be considering discussing this with a local specialist. Any patients who present with symptoms of bone cancer or sarcomas should be referred to a bone cancer center, depending on any local arrangements. And this is really, really important because I, for one, was actually referred to a center that was a cancer center, but because it wasn't a bone cancer center, I had to be re-referred on from that center to the bone cancer specialist center. So it's important, and I'll show you later where the specific bone cancer centers are. Right. We also want to look for any other red flag symptoms of the sarcomas, which we talked about earlier, which were increasing unexplained bone pain or tenderness, particularly at rest, and especially if not in the joint. So if you remember from this picture, that swelling is nowhere near my joint. It's in the middle of my leg. And if you see somebody presenting with a lump in the middle of their long bone, or even like, towards the edges, but not in the joint, that should be quite concerning, and it should raise a red flag in your mind. Anybody who also had a suspected spontaneous fracture, so they have not had any injury, but they come in and you think they fractured a bone, just go ahead and send them for an x-ray. It's really important that all of these patients get referred by the 2-week rule for both a specialist opinion and an x-ray. Okay, we're going to talk a little bit more about x-rays now. I've written on here, order a chest x-ray, but it's supposed to say just order an x-ray. So mind the C there. But just make sure that you do the 2-week wait, because if you're concerned, you should get them in soon. It could really, really save somebody their leg or their life. The Bone Cancer Research Trust has put together some really helpful resources about what radiological features you might look for in somebody that has a sarcoma or a primary bone cancer. You could look for bony destruction, newborn bone formation, any soft tissue swelling, or periosteal elevation around the bone. And I want to say this really clearly: a normal X-ray does not rule out primary bone cancer. So if someone goes for their x-ray, they've come back and it looks fine, still, please, if they have symptoms, refer them for an MRI. And the reason why is because a plain x-ray could miss up to 1/3 of cases of primary bone cancers. That's because almost 1/3 of patients experience their pain in a different anatomical location to the site of their tumor. So if they don't have an obvious swelling, but they've been having pain symptoms, bony pain, worse at night, consider getting the MRI done. Right, this poster on the left actually is one of the resources that the BCRT has put out, and it is available on their website. I found it really useful. All of their little their different informatics and their flashcards are very helpful for revision and for studying, and they're really easily accessible and they're free. So go online and download them when you get a chance, and you can share them. Brilliant. So we've now gotten our x-rays. We're going to now refer to a bone cancer center. These are specialist hospitals that have the expertise to diagnose and treat the hard tissue bone cancers. There are 5 specialist hospitals in England, and on the next slide I do have a map showing the other specialist centres in Scotland, Wales and Northern Ireland. And yeah, I probably should have put them all on here. I didn't realise how widely ranged this talk would go, but yeah, if anybody wants to know where the ones are in different places, then just let me know and we can get that resource out to you. But I personally was referred to the Stanmore. So the ones with blue stars are all the ones that are bone cancer centres that are able to diagnose patients with bone cancer. So if you seriously suspect that your patient has a bone cancer and you want a specialist opinion, then refer to one of the places with the blue stars. Because if you don't, then they're going to have to get re-referred, and it actually just adds on time to their 2-week wait. Right. This is a picture of me leaving the Bone Cancer Specialist Centre after I got my diagnosis. Now, you've all seen a picture of my leg a few slides back, and I want you to picture in your mind what kind of cancer you think it was, and I'm going to tell you now. So on this day that you see me here wheeled out in my wheelchair with my tiny little TED stockings on, I was diagnosed after I had a CT-guided bone biopsy with a high-grade stage 2B out of 3 osteoblastic osteosarcoma of the left distal femur with local spread and equivocal lung scanning. It's a mouthful. And it definitely wastes a lot of paper on all my hospital notes. But yeah, it is a very long diagnosis. Basically, what it means, high grade is aggressive. Stage 2B out of 3 is because in a lot of cancers, they grade out of 4. I think most of you will have learned this before. Stage 4 is normally when there's metastases. But in osteosarcoma, they grade up to stage 3. And stage 3 is when you have metastases. I had local spread. So my disease had spread from the femur and out into my muscles and the local tissue. And equivocal lung scans just means that they were 50-50 unsure on whether or not I had met my lungs. It was debatable. It is often difficult to tell if you have small lesions because they're basically going off of CT scans. On this day, I was deemed non-weight bearing, put straight into the wheelchair, and I was told that if I fractured my femur at this point, which I could have done by weight bearing, at the very minimum, just weight bearing, then they would probably have to amputate my leg. So I then had to take an interruption of study from medical school, which was at least a bummer. Okay, so what happens next? Well, before you start chemo, or treatment for any type of bone cancer, you need to go through all of these checkups. You do an x-ray of the suspicious area. You have to do x-rays of the lungs, because the lungs is the most common place for most of the sarcomas to metastasize, if they are going to metastasize. And normally they metastasize through the blood, not through the lymph. And that is specifically for osteosarcoma. And I'm pretty sure it's true for most of the other types of sarcoma, but don't quote me on that. They need blood testing to just check their like regular functions, an MRI and a CT scan. And they also need to do EDTA, which is basically assessing how well the kidneys can take radioactive substances, and an audiogram to check your hearing, because chemo affects your hearing, an echocardiogram and an ECG as well to just check up on your heart. So prior to starting chemotherapy, prior to having my surgery, I was started on chemotherapy. I had MAP chemo, which consists of cisplatin, doxorubicin, and methotrexate. And it was gruesome. I lost all my hair. I had all the side effects. The middle picture is showing my sarcoma on the left. You can see it bulging out in the middle of my femur. Right, so then after 2 cycles of chemo, I had limb sparing surgery. I had my femur, knee, and the top half of my tibia like hollowed out and taken away. And due to the local spread that I mentioned, all 4 of my beloved quads were resected. I had a titanium cobalt prosthesis placed, which you can see here in my x-ray. And I think that prosthesis cost more than my international medical education, so it's definitely well worth it. It's screwed up into my hip. I don't know if you can see my mouse, but up at the top by my hip, the white surrounding the prosthesis is cement, and it goes about halfway down my tibia. Unfortunately, the slide cuts it off a little bit, so you won't be able to see the very bottom, but no matter. There is no such thing as artificial muscle replacement. So you can grow your muscle fibers individually, but you cannot gain muscle fibers. So I will never have quads again in my left leg. And I was told after surgery that I may never be able to lift my leg again, but I learned with physiotherapy to use my adjacent muscles, my adductors and abductors, to lift my leg and to learn to walk again aid-free, which was quite exciting for me. All right, I hope no one's too squeamish, because the next one is a picture of my tumor. That is it there. It was pretty big, they said. When they took it out and analyzed it under the microscope, pathology had a look and found that there was some necrosis of the cancer cells, but the other half of the tumor, the posterior aspect, which is behind here, had actually grown significantly even while on chemo. So I was switched to a second-line chemo, which was ifosfamide and etoposide. I was also started on mifemertide or MEPACT, which is a type of immunotherapy. This is another picture of my prosthesis. It's just inside my leg. Sorry if anybody, well, hopefully if you're all medical students, you'll have seen more gruesome pictures before. Yeah, and so then after chemotherapy, I wanted to tell you guys a little bit about immunotherapy, because this is such an interesting thing. I think it's basically a new type of medicine where they're teaching my white blood cells to fight any recurring cancer cells, to target cancer cells, and to basically get rid of them if they ever come back. So after having the second round of chemo, I had quite a lot of side effects. I was quite ill. I was hospitalized for neutropenic sepsis 9 times. And funnily enough, I was hospitalized in the hospital where I'm training to become a doctor. At this point, I weighed just under 100 pounds, about 45 kilos or 7¼ stones. I didn't eat very much unless people came over to encourage me, or my partner forced me to eat scrambled eggs. And I just laid in bed, usually in the hospital, hallucinating and vomiting and sleeping. I used to listen to Harry Potter audiobooks on repeats, and I was visited one day in the hospital by the palliative care team. They were telling me that I was now going to be under their care, and they inserted a subcutaneous morphine driver to constantly release morphine into my system to try and make me feel more comfortable. These few months just felt impossible, And yet, like most terrible times do, they came to an end. I finished my chemo in January of 2019, so over actually nearly 2 years ago now. And I finished my immunotherapy in July of 2019. And then a few weeks before I finished my immunotherapy, I went back to medical school into my third out of 4 years. For a few rounds of immunotherapy, I actually went from placement in the morning on the tube to the cancer center for the afternoon and then back into placement the next morning because I still did not want to miss any days of school. I'm almost 2 years post-treatment now, and I'm still regrowing. I have to have surveillance scanning every couple of months, mostly to keep an eye on my lungs, where there may or hopefully may not be any cancer cells growing. And as of August 2020, just a few months ago, I started my final year of medical school at St. George's. I'm really actively involved in a few different charities, and I love sharing my story with people. I just think it's really like a nice thing to share the story, and hopefully some people will have connected to it in some way at one point or another. Right, so my final thoughts. Thank you guys so much for coming along on this PowerPoint with me. Bone cancer has been a really big part of my life for the last few years, but truthfully, prior to my diagnosis, I've checked on my medical school notes. I only wrote the word osteosarcoma down once. And I mean, mind you, that was that was in my first half of medical school, and it is perhaps like a more later year subject, but still, I barely ever heard of it. And the other last thought I want to leave you with is that from 2006 to 2016, the National Cancer Research Institute spent £387 million on breast cancer research, which, by the way, is amazing. That's fantastic. But it's sad for me because in that same time, only just over nearly 6.5 million was given to bone cancer research, which is like a fraction. I think it's just over 1%. And also bone cancer has a 30% lower survival rate. And there's a lot of research being done about how the impact of cancer on life years and the impact of cancer on disability is not necessarily equated with the amount of support and resources that are allocated to research for that cancer. And I'm really grateful for people and charities like, the Bone Cancer Research Trust and anybody who's going out there and just spreading the word about sarcoma. So if you can go away from this today and just remember that sarcomas even exist, and that in the future, if you ever see a patient that you're concerned about, remember to get an X-ray and remember to refer them on, because it's so important that we start to change things and just start to talk about it a little bit more so people know what it is. Thank you all so much for listening. I really appreciate it. Yeah, any questions, let me know. All of my slides, all the information came from the Bone Cancer Research Trust website. And if you wanted to follow the blog, it's called Squashing My Sarcoma on Instagram. Thanks, guys.
Thanks very much, Krista. That was amazing. I'm not sure how I'm going to follow that, but I'll keep it brief. So just some final kind of slides to tell you how you can be involved. So as Krista mentioned, we have developed a number of resources from our knowledge that we've picked up from patients and from our survey and from the clinicians that we work with. So we have this flashcard, which is adapted from the original that was developed by the 5 medical students from Sheffield. So we've just refined it and we've added a section in just to highlight what you need to do if you suspect and where you need to refer to, because that is a really, really important aspect. We've got a number of different resources in poster form. So we've got signs and symptoms by anatomical site in this skeleton poster, and it also covers the most common misdiagnoses at these anatomical sites. We've got the X-ray poster that Krista mentioned, and we have a GP focused poster, really, really emphasising that those quite vague symptoms need to be taken together. You need to do a full history and ask patients to describe all of their symptoms and really start putting the puzzle pieces together to get to a diagnosis. So the ways that you can carry on being involved, please use our resources and be an ambassador and spread the word, share them with your colleagues and your friends and everyone you meet. Host internal education sessions in your university with your colleagues. Please come and attend our bone cancer conference. Unfortunately, we've not had one this year due to COVID, but hopefully those will get up and running again. They're a free to attend event where patients come and share their stories and researchers share their findings. They really are a really good event. We're happy to present and give external or public lectures or supply any kind of learning resources that you might find useful. Please just ask anything that you would find useful and provide feedback on how we can help you get a better understanding of bone sarcomas. And if you would like to, you can also participate in any of our challenges or bake sales. So I just want to finish again, going back to our patients. These are our daily inspiration and why we do what we do. So thank you for listening and attending. I'll hand back over to Matt.
Well, mute would help if I took mute off, sorry. Hi everyone, thank you so much for staying with us, and thank you, Krista. That really was amazing and very moving, really moving. Well, I am the head of fundraising and communications at the charity, so I'm just going to pick up on something, Krista, that you said, and I just thought I'd give an update. So you mentioned the National Cancer Research Institute members and their investment into primary bone cancer. So the latest figures from last year, which is a bit more recent than yours, actually showed that there's been a 3-year decline in the amount of funding being put directly into bone cancer research by all the NCRI members. And actually last year it declined by a massive 17% to just 198,575. So that's it. That's all that was spent out of a total of over 700 million. So, like Zoe's just said, you can get involved and support the Bone Cancer Research Trust. We are the leading charity dedicated to fighting this disease. And we alone, as a small charity based up in Leeds with a team of 16, actually committed more than 4 times what all those national major charities put to bone cancer research last year. So when you support a charity like ours, you really, really do make a huge difference. But this is not a fundraising event. This is a educational webinar, so I will move on. Thank you so much for all your comments that have been coming in. Krista, there's such amazing comments for you. Just one in particular that stood out. Joanne Thompson in Sheffield, she said, your story is incredible and I'm sure your experience will make you an even more amazing doctor. And everybody just continues to echo those types of comments. And just how good it is that it's coming from a personal perspective. Looking up at the questions, I can see one immediate question that was from Mitali quite early on. I don't really think it was a question for this webinar as such, Mitali, but if you want to email us, we'll pick up on that. That's about you pursuing a PhD and wanting to get more involved in bone cancer. By all means, contact us and we can come back to you on that one. One question, I think just last question, but I think it's quite a nice one actually. It's a question for you, Krista. I'll just unmute you. There you go. Have you thought about what you'd like to specialise in after medical school?
Oh, I get that question very often when I do these talks. And I often say that I think it would be very poetic if I became an oncologist. But we'll see. I really like emergency medicine, so we'll have to see.
Fabulous. Well, I'm sure you'll be great at whatever you choose.
Absolutely.
Thank you.
So, okay, we'll draw it to a close, everyone. We will send you an email, probably tomorrow now, which will include a link to a video recording of this webinar. As Zoe said earlier, please do share it. in the email that we sent you earlier and the one we send you tomorrow, there is a link in that email to our downloadable information materials, the ones that you've seen on this presentation. So please do access them, use them, spread the word, put them everywhere. And if you want anything printed and sending to you, contact us. We'd be delighted to send that out to you. And if you have any other questions after the webinar, please do get in touch. Also, really important to us, on the email that we send you tomorrow, it will also have a very short survey on it, only 7 questions. If you wouldn't mind completing that for us, that would be great, because it just helps us know whether or not this has been useful to you, whether or not the format is right, and how we can improve to do more. This week is Bone Cancer Awareness Week, hashtag Bone Cancer Awareness. Please do share that you've been on the webinar on social media, spread the word that way, and keep an eye out on our posts, share our posts, and get involved however you can. So thank you all. Thank you ever so much, Krista, once again.
Thank you.
And good night, everyone.